Hi, everyone. Thanks so much for joining us today. My name is Hope Avalone, and I'm the Senior Manager of Patient Education here at the Lymphoma Research Foundation. And in my role, I work every day to help educate patients and their care partners. And on behalf of our team, I want to warmly welcome each of you to today's webinar, Oral Therapies, Treating Lymphoma and CLL at Home. And before we begin officially, I wanted to just review the ways that you'll participate in today's program. Primarily, you'll be using two buttons at the bottom of your screen. If you run into any technological issues throughout the program, please use the chat button and I'll be happy to assist you. If you do have questions that you'd like to be asked to our speaker, please submit those through the Q&A button. Any questions submitted through the Q&A button can be made anonymous. Just make sure to check the box before sending them in. Also, I won't be reading off any first or last names when reading off the questions. At the end of the presentation, we'll have some dedicated time for the question and answer session. I do also want to mention that any medical information provided today is not a substitute for professional medical advice, diagnosis, or treatment, and that certain questions might not be appropriate to answer comprehensively in this format, but we always encourage you to discuss any information you hear today with your provider or your care team. For now, let's officially get started. Welcome again to today's webinar. We're so grateful to our supporters who have generously sponsored today's program. And after the program today, you may have additional questions about lymphoma, treatment options, and supportive care. And I highly encourage you to explore the Foundation's new Lymphoma Resource Center. Whether you're a patient, a survivor, care partner, or loved one, you can now access information and get your questions answered all in one place. The Resource Center is here to help you by offering a range of services, including financial assistance, treatment navigation, and comprehensive disease information. Our support team can also connect you with someone else who has experience with your subtype or treatment plan. For example, if you're interested in connecting with someone who has experience with oral therapies, that's an option. Everything we offer is, of course, free and designed to support you at every stage. You can visit lymphoma.org/resource center or contact our team at 800-500-9976 or at connect@lymphoma.org. We also offer a robust selection of patient materials specifically on oral therapies so that you can feel more supported and informed. This includes our oral treatment options and adherence guide, which covers targeted therapy, chemotherapy, and immunomodulatory agents. And we also have comprehensive guides on lymphoma subtypes, other treatment options, and supportive care topics. You may also want to utilize our lymphoma care plans to help you and your physician document your experience. We do also have some additional webinars coming up that you might be interested in. I've listed information here for webinars on chronic lymphocytic leukemia and small lymphocytic lymphoma, diffuse large B-cell lymphoma or DLBCL, and also our upcoming webinar on advocacy and drug development. Finally, registration is now open for our annual educational forum on lymphoma, which is a 2-day virtual conference. And this year's Ed Forum has a robust agenda that will cover trending topics like artificial intelligence, aging and lymphoma, research funding, vaccination, and minimal or measurable residual disease. It will also, of course, include individual breakout sessions for each subtype of lymphoma, as well as various treatment options, including oral therapies. So you can visit lymphoma.org/edforum to learn more and to register. Now, I'll be back later in the program to moderate the question and answer session, but for now, it's my absolute honor to introduce our speaker today, Dr. Jonathan Cohen. Dr. Cohen is a hematologist oncologist specializing in lymphoma at the Winship Cancer Institute of Emory University, where he is a professor in the Department of Hematology and Medical Oncology. Dr. Cohen is a member of the Foundation's Mantle Cell Consortium, and he's contributed greatly to our programs for both patients and physicians. And we're so grateful to have him back for this webinar today. So without further ado, I'll now turn the talk over to you, Dr. Cohen. Thanks so much for being here.
Great. Well, thank you so much, Hope. It is always a pleasure to work with the LRF. And as you point out, I've had the opportunity to work with this team for a long time over the past several years in a number of different ways, and it's always a fantastic opportunity for me. So thanks so much for having me this morning. Today we'll be talking about oral therapies in lymphoma and CLL. And As you might imagine, this is becoming an increasingly relevant topic for more and more patients as we are developing additional oral therapies and learning about how best to utilize them in the management of lymphomas and CLL. These are just some of the disclosures related to some of the work that I do in drug development and clinical trials. And then these are some additional disclosures that I think are probably more relevant to today's talk. So the first is I want to highlight, and I know Hope brought this up as well, that this is not a comprehensive discussion about all oral therapies and all scenarios where they may or may not be used. It's critically important that, number one, if you are receiving an oral therapy or considering it, that you have a conversation with your physician and treatment team, and I'll go over some questions that would be appropriate to ask at that time. Um, but there are certainly things that may or may not apply to your particular situation. So I want to point that out ahead of time. And again, always consult your treating oncologist whether a therapy is appropriate for your specific case. As we are getting better and better at treating lymphomas, we're also getting better at identifying which specific types of lymphoma may benefit from individual treatments. And so it's becoming more and more nuanced every day. And so it's really important that you have a thorough conversation with your treating physician to make sure that you are aware of all the options and recognize when oral treatment is your best option, or maybe perhaps you'd be better served by a different approach. Many oral therapies, some of which I'll excuse me, be discussing and otherwise are being investigated in clinical trials. And so this is certainly not a totally open and shut case. We're learning more and more about individual treatments all the time and how best to combine them and when to use them and how long to use them. I think there still is a lot that we'll be learning about clinical trials. And then the last thing I would say is that occasionally off-label use of oral therapies can be appropriate, but this is again something that I would recommend that you do obviously in close consultation with your oncologist and based on your individual case. So these are just some of this is the primary outline. So we'll talk about lymphoma treatment in general very briefly. I'll go over some common myths and misconceptions related to oral therapies that I hope to use this time to address. I'll go over some very broad strokes with regards to individual diseases where we think about using oral therapies. And then at the end, I'll talk about some talking points and questions, things that I think are important when you're talking with your oncologist to consider and to clarify. So let's first talk about the many different ways that we think about treating lymphoma and CLL. And on this slide, I've highlighted a number of the different approaches that we would think about using for individual patients. And many of you may have received or been managed with any number of these. So observation or watchful waiting is something we commonly think about in patients with CLL or other indolent lymphomas that don't necessarily have active symptoms, that don't have a very large burden of disease. And many of these patients will do just fine often for many years without needing any treatment. And so that still continues to be a very common approach for me in my own clinic. We still sometimes will use traditional chemotherapy. So this is treatment that may have been around for a long time, but can still be quite effective. The most common scenarios are where we're using traditional chemotherapy or for the more aggressive lymphomas. But again, this is still a very viable option for many patients. And although there's a lot of interest in moving beyond chemotherapy, I would just highlight that for many people and many diseases, this is the best option and still something that I use in my own clinic. There are the immunotherapies or cellular therapies. There's been a lot about this in the press of late. This includes antibody treatments like rituximab or obinutuzumab or tafasitamab that have a specific target that they are attached to. Antibody drug conjugates, where we take an antibody that is targeting a specific target like CD20 or CD19 or CD30, and we attach it to a chemotherapy molecule, and it's sort of like a smart bomb where the antibody seeks out the lymphoma cell and it then can attack it sort of delivers the payload, delivers the chemotherapy. And so there's a number of those that are currently approved in B-cell lymphomas. The bispecific antibodies are sort of the newest on the block. These are one antibody molecule with two targets, and then CAR T, which is where we actually engineer your T cells to attack your lymphoma. These are very exciting, can be very effective, and are being used more and more earlier and earlier on in the course of therapy. As some of you may be aware that have been on any of these treatments, they have their own set of side effects and toxicities, and some need to be given in the hospital. And so, although they're very exciting, it may or may not be the best option for an individual patient given a given situation. We have radiation treatment, which can be highly effective. And then we'll talk about today a number of oral therapies that you take at home that can also maintain good control of the disease for a long time. And I would highlight here, many of you that need treatment will ultimately receive several of these approaches. And so, although at a given time we might be choosing one particular treatment based on the risks and benefits and everything that's going on, I always remind folks that if necessary, there are a number of options that will be available throughout their disease course. And just because we go one direction at one given time doesn't mean that down the road, if we need to make a different choice, that we can't. So, in general, when we think about the oral therapies, there are pros and cons. So, the pros are the things that might seem most obvious. So, it's convenient. You take it at home. You don't have to come into the infusion center. You don't have to come get an IV. You don't have to go to the parking garage and pay for parking and wait in the waiting room and all the different things that you have to do in order to receive therapy at a cancer center. You don't need to have a port, and so again, the convenience aspect is a big pro for many of my patients. They can work, they can travel, they can live their life in a more normal way. They may have less severe toxicity. There are still side effects that we'll talk about that need to be considered, but they sort of pound for pound may have less toxicity compared to traditional chemotherapy. And in some cases, they also can be more effective. And so sometimes people will think, oh, well, if it's an oral therapy, it may not be as effective as more aggressive chemo, and that's not always the case. For many people, they like the idea that you are continuously treating your cancer. So on a daily basis, you're taking a medication that you know just from that you know is working to try to control your cancer. And then again, the scheduling is a lot easier for travel and work and other things. On the other hand, adherence can be difficult. So, especially if you're somebody that's not accustomed to taking medications regularly, all of a sudden taking a pill once a day or twice a day can be difficult. Or if you are traveling and you forget to take it with you, or any number of things that can come up that can make it difficult to be adherent. And so, it's one thing to know that you have to come to the infusion center once every 3 weeks and you know that you're there and you're going to get what you need, but to try to make sure that you're taking that medication every day on schedule can be difficult. There can be costs involved, out of pocket costs, depending on insurance coverage, and there can be some hassle. So, this is not something that we just send to CVS or Walgreens. This is something that goes through what's called a specialty pharmacy that your team typically will work with, but there's a process for obtaining the medication. There can be some chronic side effects. So, again, if you're talking about a 6-month course of chemotherapy, there may be side effects that can be difficult to manage, but then once the chemo is over, often people recover and get back to baseline or pretty close to baseline. Whereas if you're on an oral therapy, even if the side effects are less intense and less disruptive, if they're chronic, they can really become annoying. And so I give an example, for example, of nausea or diarrhea that might be low grade. It may not prevent you from eating. It may not keep you from doing the things you want to do. But if you're living your life and feeling some mild nausea on a daily basis, that can really start to become old after a long time. And so those are all things that we keep and take into account. This is a chronic therapy that's given over a long period of time. And then it can also interact with other medicines. And this is something that you have to take into account, especially if you're on a medicine for a long time. Clearly some benefits, but it does come with some trade-offs that we talk about and that we manage with individual patients. So let's talk about some myths that often come up, at least in my own clinic, when I'm talking with patients about oral therapies. So the first is that oral therapies are not quote unquote chemo, and therefore they're less toxic. And the truth is that this is commonly the case. There often are different types of side effects that we see with oral therapies, but they still can be severe. They still can even be life-threatening. And so it's very important that if you are on an oral therapy, that you take this seriously and that you do keep an eye out for side effects that you might be experiencing that could be related to the medication. This is not necessarily less toxic. It's just often more of a different toxicity profile. And then the counter to that is that, well, this might be less toxic, it may be easier to take, but is it less effective? Am I not getting the strongest treatment that I can get? And the truth is that there's been a number of studies that have shown that oral therapies can actually be more effective than traditional chemotherapy. We've seen this most notably in the CLL space, but this is also something that we've seen with other diseases. We've also seen studies that suggest that adding an oral therapy to chemo is considerably better than just doing the chemotherapy by itself. So the oral therapies are a very highly effective treatment option in many cases. And so if your physician, your oncologist recommends this, this is not necessarily because they think you can't tolerate the best treatment. It may be that this really is the best therapy and most effective therapy for your lymphoma. Another concern that comes up is that oral therapies are safer than chemo. So there's not the same risk of infection. So if I'm on a chemo pill or an oral pill, I don't have to worry about infection. I don't have to worry about some of the things that I have to think about when I'm on chemotherapy. And unfortunately, we have seen several severe infections that have come up in patients that are on oral medications. In some ways, in some scenarios, we can give medication to try to prevent this, but there are significant risks associated with this. And so it's not that it's common, it's not that it happens all the time, but it's important to recognize that you can have these sorts of complications and that it does require you to have ongoing communication with your oncology team. And if something comes up that seems out of the ordinary, that you communicate promptly so that we can make sure that we get this addressed. And then another concern that has come up, which is unfortunately a challenge still, is that oral therapies are prohibitively expensive for many patients. And the truth is that with very, very few exceptions, if you were to try to pay entirely out of pocket for an oral medication, it would be prohibitively expensive. And depending on the medication, it can be several $1,000s every month, which is, again, for the vast majority of patients, is not necessarily in the budget. But the truth is that almost all eligible patients, meaning patients that we feel like are likely to benefit from treatment and where we feel like an oral therapy is the treatment of choice, are able to receive the therapy at a reasonable cost. And this is because there are, first of all, many insurance providers will cover a large portion of the cost of the medication, and so we work with insurance providers. But in addition, in many cases, when there is a gap in what the insurance covers and what a patient may be able to comfortably afford, there are a number of programs out there, some through the pharmaceutical companies themselves, others through organizations that are able to provide support to help make this a more affordable option. The most important thing I can tell you is that you have to let your oncologist know if the cost that is being quoted to you for an oral medication is not something that's in your budget. What I found, at least in my own clinic, is that often patients may not consider themselves to be, quote, needy or to be in a category where they would think about getting patient assistance or other sorts of assistance for medical costs. But the truth is that the overwhelming majority of patients will qualify for some assistance. And so it's not something to be embarrassed about. It's not something that where you're being annoying or you're being greedy. This is a common part of the process of obtaining oral therapies for patients. And so if you have a copay or coinsurance for your oral therapy that is not something that you're comfortable with, please communicate with your team. We would much rather you do that than have to stop taking it after a couple months because you can't afford it, or have to take it in a different way than normal because you're trying to spread it out. So please do be upfront. And again, it is not something to be embarrassed about. The vast majority of patients that I care for receive some sort of assistance to help make sure that the cost is manageable. Now, when we talk about oral therapies, the truth is that there's a variety of different types of oral therapies. These are not all the same. They're not all used for the same indication. So this is a list. This is not meant to be absolutely exhaustive. And so there may be therapies that you've received either on study or outside of trials. But this is a fairly good representative list of the types of treatments that at least in my own clinic, we think about. So chlorambucil, which is used much less frequently currently, is an oral therapy that occasionally we think about in patients with CLL. Again, it's very uncommon that we would use this at this point, but this is actually a true chemotherapy oral agent. It's been around for a long time, and this is just a conventional chemotherapy in pill form. Again, that's much less commonly used. The immunomodulators, and so at least at present, we have lenalidomide, or sometimes goes by the name Revlimid, which has been used in a number of different settings, either by itself or in combination with other treatments. It's used sometimes in mantle cell lymphoma, follicular lymphoma. It's very commonly used, especially in the relapse setting. And then now it's used in combination in diffuse large B-cell lymphoma. And so this is a therapy that you might think about using. Again, it's typically not used by itself, but in combination with other treatments. And then I would say the most commonly prescribed oral therapies, at least in my own clinic, are the BTK inhibitors, or Bruton's tyrosine kinase inhibitors. As you can see, these are used in a variety of different lymphoma subtypes, including CLL, mantle cell, marginal zone, lymphoplasmacytic lymphoma, as well as follicular lymphoma. And there are four BTK inhibitors that are currently approved. As many of you may know, ibrutinib, which was the first one to be approved, has been withdrawn from the US market for several indications, but is still occasionally utilized, whereas acalabrutinib, zanubrutinib, and pirtobrutinib are all commonly used and for a variety of different indications. And then there are BCL2 inhibitors, which is a different class of oral therapies that are approved in CLL in the case of venetoclax. And just recently, sonrotoclax is a next generation BCL2 inhibitor that has now been approved in mantle cell lymphoma. So as you can see, there's a variety of different options. Again, this is not meant to be absolutely exhaustive, but just want to highlight that when we talk about oral therapy, it certainly is not a one size fits all. Now, one thing that I do want to highlight is that unfortunately, not all oral therapies have proven to be effective and safe in the long term, and we have unfortunately had a handful of examples where we've had an approved agent that has had to then be withdrawn from the market. The most commonly known ones are what we call the PI3 kinase inhibitors, and idelalisib was the one that was the most notable of these. Some of you may have been on one of these therapies in the past, and unfortunately, these were actually very effective treatments. But especially during the COVID era, we identified a very high risk of infections that made this much more difficult to use, and has resulted in the withdrawal from the market in almost all cases. Tazemetostat was more recently withdrawn from the market, and selinexor also is no longer, to my knowledge, is no longer approved for diffuse large B-cell lymphoma. These are agents that had been very promising, but over time were felt to not be as safe as we had hoped. And I just highlight this because it is important to recognize that, as I mentioned, that there can be some long-term side effects with oral therapies. Fortunately, we do have ongoing follow-up for many of our clinical trials, including now 10 to 15 years out for some of the oral therapies. So we really do have the opportunity to continue to monitor and make sure that they continue to be safe. And fortunately, what we're seeing with the BTK inhibitors, with BCL2 inhibitors, and lenalidomide is that these do continue to have a very good safety profile. But again, it highlights the fact that ongoing follow-up is important, and again, that it's important that you continue to communicate with your physician, as there may be some newer findings that come up that need to be addressed. Now, is an oral therapy appropriate for use? So, for a very long time, and I remember even when I was in training, there was a lot of discussion with, wouldn't it be great if somebody had cancer and you prescribed a pill, just like you might for blood pressure or diabetes? You prescribe a pill, it treats the cancer, and they go on about their business. Um, and so for that reason, there's been a lot of interest in utilizing oral therapies. And I think in most cases, it does, as I pointed out before, result in a significant improvement in quality of life. And so I've highlighted here where, at least in my own practice, I think about using oral therapy. In CLL and SLL, that is probably the most common time when I'm using oral therapies in a very standard fashion. Follicular lymphoma and marginal zone lymphoma, especially in the relapse setting, we think about it. Mantle cell lymphoma, either in combination with chemotherapy or sometimes as by itself, we're using it, and then you can see some of the others. For aggressive lymphomas and T cell lymphomas, it's much less common that you would use an oral therapy by itself. Um, Sometimes in T cell lymphomas, but for the aggressive lymphomas, often it's used in combination. Now, outside of the setting of a clinical trial, classical Hodgkin lymphoma, I'm typically not thinking about oral therapies or Burkitt lymphoma. And again, this highlights the importance of continued investigation of new treatments so that we can, if there are oral agents that are particularly effective for those groups of patients, that we have those to offer as well. So let's talk about some of the individual classes. And again, this is not designed to be exhaustive, but just to give you an idea of the types of discussions that we have in clinic. So the BTK inhibitors, which again are currently used in a variety of different lymphoma subtypes, can be quite safe, and many people don't even know that they're on it. But there are things that we comment or that we counsel patients about. So bleeding and bruising is one of the primary concerns with the BTK inhibitors. This is particularly relevant if you also are on a blood thinning medication like Eliquis, for example, or any other blood thinner. Uh, those are scenarios where you do really have to be very careful. And I counsel patients that if they were to fall and hit their head or be in a car accident or have some sort of unexpected trauma, that it's very important that they communicate with their team that they are on these medications and that their bleeding risk would be higher. Similarly, if you are going to be having surgery, we tell patients how important it is for them to let their surgeon know, and often will hold treatment for a couple of days before and after the surgery. Fatigue can be a challenge in some cases. This is often difficult because the disease itself causes fatigue, but I will at least let patients know to be on the lookout for this. Blood rhythm abnormalities can occur, and then you can see there's a number of others: infectious complications, hypertension, joint aches, and so forth. Now, often I will go over this with patients, and they'll be like, "Well, that doesn't sound so good." And fortunately, most patients will not experience all of these, and many will not experience any of these. But I always like folks to be on the lookout, especially because they're going to be on treatment for a long time. And I would highlight that within the BTK inhibitors, there does seem to be some differences in toxicities. And so, again, when you are deciding to go on a BTK inhibitor, it's very important that you discuss with your doctor which one you're going to be receiving and what are some of the side effects to be on the lookout for. Now, venetoclax, the BCL2 inhibitor, the most common side effect is something called tumor lysis syndrome. This is when the cancer cells are breaking down very rapidly, and as a result, the contents that were inside those cancer cells are going out into the blood. And so this can result in a high uric acid, which can impact your kidneys in particular, as well as electrolyte abnormalities. And so this is something that we have a process to mitigate. We've been doing this now for quite some time, and so we've got a very good process to do it. But it's important that you have a conversation with your doctor about it. If you're going to be thinking about venetoclax, it's very important that you are hydrating, drinking water, and then there's medication that we would also give you during that first cycle. And then all patients will typically complete a ramp up process to make sure that we're doing everything we can to prevent tumor lysis syndrome. And while this was something that was a significant challenge for the first couple of years when venetoclax was available, given the time that it's been available and our experience now, this is something that fortunately happens very infrequently, just based on all the processes we have in place to mitigate the risk. And so again, if you're going to be receiving venetoclax, it's very important that you continue to drink large amounts of water. That's something we remind our patients about every single day or every single week when we see them. Commonly, we'll combine this with an oral medicine that you at least take for the first couple of weeks. I tell people to plan on coming to see us once a week. And it's important if you're going to be receiving venetoclax that you get started at a time when you have some flexibility with visits. Commonly, I'll tell people that they may be coming in once a week for even up to 6 weeks to get labs drawn. Sometimes it's more frequent, sometimes it may be a little bit less, but I think it's critical that you recognize that this first part, there's going to be a hassle factor um, to consider. The good news is, though, that if this happens, it's fully reversible. There doesn't appear to be significant long-term complications for the vast majority of patients. It's just something we need to watch for and manage. And then other than that, once people get started on therapy, there often is some GI side effects. It's usually not unbearable, and there can be some neutropenia or lowering of one of the white blood cells. So these are all things we keep an eye out for. But what typically, once you get through that initial part, patients do quite well. For lenalidomide, probably the most significant side effect that we are thinking about is thromboembolic disease or blood clots. Often I'll use an aspirin or other blood thinner to try to prevent this. In a patient who's had blood clots before, again, this is particularly relevant, and so it's important that patients are aware of this. In addition, this is a very close relation to thalidomide, which many of you may be familiar with from decades past and was associated with birth defects and birth anomalies. And so as a result of this, every patient that goes on lenalidomide goes through counseling about avoiding pregnancy and not having women of childbearing potential sort of managing the medication. And so this is something that we take very seriously. And then you can see some additional toxicities. And this is a medicine that we commonly have to adjust the dose based on fatigue or other side effects. And so, again, this is something that does require ongoing management. And then just talking about some of the diseases themselves. So for CLL, oral therapies I would consider are the standard of care. They've been compared multiple times to chemotherapy and pretty much always compare favorably. I cannot remember the last time I treated a patient with CLL with traditional chemotherapy. And so this really is the standard of care. And if you have CLL and and you're being recommended to do a more traditional chemotherapy, I would be sure to talk with your team about why they're recommending that and not an oral treatment, because I think in general, oral therapies would be the standard. Both the BTK inhibitors as well as venetoclax are very highly active, and most patients will receive both of these at some point during their treatment course. So as you may know, CLL is a chronic disease. It's a disease that tends to recur at some point. And so if you start somebody on a therapy in year one, by year 10 or 12 or 15, they might need a different treatment. And so often they'll end up receiving both of these. And for CLL at this point in 2026, the real decision at the time therapy is needed is less about should I receive oral therapy, but what type of oral therapy should I receive? Because both the BTK inhibitors and venetoclax can be very effective. And this is just highlighting some of the differences. So the BTK inhibitors are typically given indefinitely. And so you stay on that medication as long as it's working and as long as you're not having significant side effects. There are large clinical trials that have highlighted the improvement of the BTK inhibitors compared to um, compared to chemotherapy, and it's convenient. So there's no infusion, there's no monitoring that's required. Typically, I start somebody on this, and assuming they're doing well on it, I see them once every 3 months or so, and they go on about their life. On the other hand, venetoclax is typically combined with another antibody called obinutuzumab, or sometimes it goes by the name Gazyva, so we call it Ven-G. This is a 1 year course of treatment. So as opposed to the BTK inhibitor, you receive this treatment um, for only 1 year. You don't have some of the same cardiac risks. You don't have some of the same bleeding risks, but there is the TLS concern and the issue with having to ramp this up. One thing that I think is important is that this is only a year of treatment, so there is also the potential for cost savings. Now, some of you may know that over the last year or two, there's been some newer data that have looked at the combination of the BTK inhibitors plus venetoclax. There was a large presentation at our big annual meeting last year, and there was an additional study the year before. This is a time-limited approach with all oral therapies, and so this is obviously very exciting. The idea of not having to come into infusion is very appealing. In my own mind, I think we're still waiting to see how patients that receive these two therapies do long term. The one question I do have is if you've received both of these classes of drugs already, what may happen when you recur down the road? And so those are all things that I'm eagerly awaiting follow-up for to see before sort of making a wholesale change. But this is a very exciting new approach that does potentially offer the opportunity to avoid IV therapies entirely. In mantle cell lymphoma, we have the approval of acalabrutinib and zanubrutinib, which are commonly used now in the frontline setting. If you didn't receive them up front, you might also receive them if your disease recurs. Pirtobrutinib is a newer BTK inhibitor. It works in a little bit of a different way, and so often we think about this in patients where acalabrutinib or zanubrutinib are not as effective. As I mentioned, sonrotoclax was just recently approved, and we are excited to have this class of drugs available in mantle cell lymphoma. And then lenalidomide also has been evaluated both in the upfront and the recurrent setting. I don't use it quite as frequently in mantle cell lymphoma, but it is certainly an option. One thing I would point out with the oral therapies in mantle cell is that the remissions don't tend to last quite as long as we see in CLL or SLL. And so again, it's important to recognize that this is a different disease. And as a result of the remissions not necessarily being quite as durable, often we're still using this with chemotherapy to sort of augment the chemotherapy as opposed to replace it in many cases. Although there are some specific scenarios where we might avoid the chemotherapy. And again, this is a pretty nuanced discussion that's not necessarily within today's scope, but I think it's important to highlight the fact that often the oral therapies are given in combination in mantle cell lymphoma. And then in follicular lymphoma, commonly we're still using chemotherapy as our initial treatment, but lenalidomide is very frequently used in the relapse setting. And as some of you may know, there's been a couple of different trials of late that have highlighted its use with other novel treatments that look quite good. And so this is something I commonly use in that setting. And then zanubrutinib has now also been approved in the relapse setting. And so for most of my patients with follicular lymphoma, even if they don't receive the treatment at the very beginning of their treatment course, they will end up getting an oral therapy at some point. And I would guess that in the next 5 to 10 years, this may be the disease where we really start to see oral therapies potentially start to take over in the front line as well. And so a lot of research being done to identify when is the right time to use this in follicular lymphoma. Now, as opposed to these others where we use oral therapies all the time, in diffuse large B-cell lymphoma, which is the most common aggressive lymphoma, the oral therapies in general have been less promising. Now, not entirely, and there's a lot to that, but I would say I've been using them much less commonly. Several studies, though, have looked at the role of R-CHOP, which is one of our standard backbones, plus an oral agent. And historically, these have not had significant improvement. Recently, just this year, however, we've seen the data from the Frontmind study, which was a study of R-CHOP plus tafasitamab, which is an antibody targeting CD19, plus lenalidomide. And this does look to be very promising. It looks to improve on R-CHOP alone. And so this is something that may be coming soon to a clinic near you. It does introduce some scheduling challenges and some monitoring that needs to take place, but it does look to potentially be a nice option for patients if needed. And then in the relapse setting, we often think about lenalidomide in combination as well. Um, for the most part, though, oral agents I still consider to be part of a clinical trial setting for aggressive lymphoma, other than some of these lenalidomide combinations. So as we get toward the end of at least my portion today, I want to highlight some talking points or things to be thinking about when you are talking with your oncologist. And it's very important, number one, to discuss the goal of any treatment that you are going to be receiving prior to starting it. So how will you know that it's working? So is this something that we're going to be monitoring blood work? Is this something that I'm going to need to get scans for? How do we know that it's working, and what are the types of things that we'd be looking for? When will the treatment stop? So is this something I'm taking indefinitely? Is this something I'm taking for a year? How will we make the decision? And the reason that this is important is that you want to make sure that this fits within your goals or lifestyle. So if coming once a week for a ramp up is not something that's going to be feasible for you, then doing venetoclax, at least at that time, may not be the right option. On the other hand, if you really are reluctant to commit to a long-term course of treatment, then you might be willing to add on that hassle for the first month or so in exchange for being able to come off the treatment at the end of the year. So it's very important to have these sorts of conversations before you start, to make sure that what you're going to be receiving is going to make sense. The other thing I would say is that it's really changed our thoughts about toxicity. So side effects used to be something that happened for the couple months you were receiving chemotherapy. For the most part, you recovered from it, and that was that. Now, however, when folks are on a longer term course of treatment, there can be some ongoing side effects that might be minor but can be problematic. So joint aches, for example, that might be something you're willing to put up with for a few months, but you might not be too enthusiastic about putting up with that for 5 years. And so it's important to highlight that. There are some toxicities that may emerge later in the course of treatment. As I pointed out before, we've seen some of these toxicities that have been pretty significant. So again, it's critical that you maintain contact with your oncologist and your treatment team. And as I point out, we're still learning about some of these long-term side effects. And so for the BTK inhibitors, and now for venetoclax, we have many years of follow-up, but we continue to monitor those patients that were some of the initial ones treated to make sure that there's not something new that's emerging that we weren't aware of. And more is not always better. And so there's a lot of interest in trying to combine therapies to see if we can improve outcome. And we don't necessarily know that 2 drugs or 3 drugs is better than one. Again, this is where you want to talk about what is the goal of the treatment. And if I take 2 treatments, does that mean that maybe I can discontinue therapy earlier? Is it not going to matter, and I'm just going to be on more therapy for a longer period of time? And the reason I bring this up is that, especially for some chronic diseases, it's possible that taking these treatments in sequence may be just as good at taking them in combination. And so if you can take one therapy for as long as it works and then take a second therapy for as long as it works, it may be that you do just as well in that scenario than taking both of them the entire time. Some of this we're still learning, but again, it's important to have a conversation with your doctor about the regimen they're recommending, why they're recommending it, and if that's the only option. And then communicate clearly with your team about costs. As I pointed out before, it's very important that you take this treatment on schedule and regularly. So if you don't feel that you can maintain the schedule because of cost, because of your lifestyle, because you're just somebody that struggles to remember to take medications, for whatever reason, I think it's very important that you highlight that to your team. And as you can see, we can almost always work out a way to obtain therapy for a reasonable cost. We can almost always identify a way for you to be able to manage it at home. But if you don't bring it up, if you don't highlight some of the challenges that you're having, it can be hard for us to make sure that we are addressing them. So please be sure to let us know. I would also just point out that LRF, as Hope mentioned at the very beginning, has a lot of resources to help with sort of managing being on treatment, and so they may have some ways to help ensure that you are being adherent. They have folks that you can talk to. They have other resources that you can utilize to to facilitate sort of being on therapy and helping you understand the treatments and so forth. So, in addition to your treatment team, there are other organizations out there that can also be a resource. So just some future directions. So we are still refining treatment duration for in many cases. Sometimes you're on treatment until it stops working. Other times you might only be on treatment for a shorter period of time. I think we're still learning the optimal therapy for individual patients and individual diseases. Chemotherapy plus oral agents are often combined. So I mentioned this a little bit with diffuse large B-cell lymphoma and with mantle cell lymphoma. This is something that we're seeing fairly frequently. Again, so when you're going to be on treatment, make sure that you're talking to your physician about if you're going to be on an oral agent, how long you'll be on it, what it may add to the chemotherapy, and so forth. There are new immunotherapies and BiTEs that are available and others being developed that are also part of the discussion here. These are also non-chemotherapy approaches that are very exciting. They do require you to come in to be treated. They do have some specific toxicities that need to be considered, but it's important to recognize that that an immunotherapy may be a better option for a given patient at a given time. And then we continue to work with molecular assessments to identify the most appropriate treatment. And so this can be things like FISH tests in CLL or TP53 mutation testing, or any number of other assessments that we do that may help us better target therapy for an individual patient. And so I think it's just important to keep this in mind, and we're becoming better and better at identifying who are the right patients for the right treatment. And then my last plug would be that if you have an opportunity to participate in a clinical trial, I would highly recommend that you strongly consider this. These are very exciting therapies, and I think that they are a key part of the future of lymphoma treatment. And so, if offered the opportunity, I would certainly recommend that you strongly consider it. It may or may not be the right option for you at a given time, but this is how we continue to improve outcomes for patients and improve our understanding of these treatments. So with that, I know there are likely a number of questions, but I just want to again thank Hope and thank the LRF for the opportunity. I think programs like these are incredibly valuable for patients, and would encourage you to make use of the resources available through LRF, whether you're on an oral therapy or if you have questions about other treatments. So thank you very much.
Thank you so much, Dr. Cohen, for your excellent presentation and really for mentioning the foundation as a resource. I do want to just kind of mention that if you're interested in clinical trials involving oral therapies, you can definitely contact our support team and they can help you look into some options that might be the right fit for you so that you can understand really all of the possible treatment options out there that include clinical trials as well. So um, definitely we'll be taking some questions now with the rest of our time. Dr. Cohen, you addressed so many of them already, so some of these might be a review, but I wanted to get started with some questions about BTK inhibitors that I'm seeing. So we did get a few questions about ibrutinib. Can you just reiterate when and why it was taken off the market? And we have a few patients who are still taking ibrutinib and they're wondering if they should be concerned or what to know about the withdrawal.
Sure. So that's an important question. This was I'll be honest, I can't remember if it was 2024 or 2025, but within the past couple of years, it was withdrawn from the market for several indications. And I want to be very clear that this was not due to any new safety concern or any new uh, efficacy concern or anything like that. Okay. I have patients in my own clinic that are on ibrutinib. They've been on it for a long time and are doing just fine. What had happened is that there were some studies that were as part of the sort of the regulatory process and the FDA approval process. There were some additional studies that were conducted to further evaluate the benefit of ibrutinib in lymphoma and specifically in mantle cell lymphoma. And the particular study that was done did not ultimately show a significant improvement with ibrutinib when it was combined with a specific chemotherapy in one trial. And so because of that, it was withdrawn from the market. That does not mean that it's still not a highly effective therapy for mantle cell lymphoma and CLL and other lymphoma types. If you're on it and you've been doing really well, it is not something that you need to stop. But if you are having side effects and you're interested, there are other approaches. And certainly, if I were starting somebody now, I wouldn't be starting them on the ibrutinib. But just want to reiterate that this was not. It wasn't that we all of a sudden found out it was not safe, or that we all of a sudden found out that it was not effective. This was sort of a nuanced decision related to a trial and sort of the regulatory approval pathway.
Thank you for clarifying that. And we did get some questions about zanubrutinib or Brukinza. So the first one here is I've been taking Brukinza for several years, and it was recommended that I take it with water, but I've been taking it with orange juice. Is that okay, knowing that Brukinza should not be taken with grapefruits?
So that generally should be okay. The part of the issue sometimes with like grapefruits as an example, it has more to do with the way that the drug is broken down in the liver. And sometimes or grapefruit juice in particular can affect that. So as a general rule, I would say that that's probably fine.
Thank you. The next question here is, are there any recommendations for how to manage joint aches caused by BTK inhibitors?
Yeah, so that can be challenging. I think that certainly trying your best to maintain physical activity is important. So we know that, and that goes for any sort of joint related concern. So, if making sure that you're walking, making sure that you are exercising as able is always a good idea. It also is reasonable to take Tylenol, for example, if that helps you. We sometimes get a little bit more concerned with ibuprofen, just because if you take that in large amounts, it can affect your kidneys or can increase your bleeding risk due to GI upset. But even a dose or two of ibuprofen is probably also fine. If you are needing, however, more support than that, then that's a time when it's very important to talk with your oncologist, because sometimes you can reduce the dose and we still find that it can be very effective. Sometimes there's a need to switch to a different BTK inhibitor. So this is something that gets back to what I was saying before about the importance of communicating with your physician. But sort of many of the sort of traditional things we think about for joint health or joint fitness are at play here, but sometimes it's just a matter of needing to reduce the dose.
Thank you. And st kind of sticking with side effects of BTK inhibitors and for zanubrutinib specifically, I know you mentioned that these therapies can cause diarrhea. One patient noted that they're experiencing constipation. They're wondering if that's something that you've seen. They say they have fructose malabsorption, and they're wondering what they can do to help constipation if it's related to the drug.
Yeah, so it's interesting. I've had a few patients where that's come up, and sometimes it can be difficult to know if it's really from the drug or not. Um, Unfortunately, in many cases, the only way to know for sure is to stop it and see if the symptoms get better, and then at least you know that it's related. Um, I would say that if it is something that is manageable with a stool softener or a gentle laxative like a Senokot or a Docosate, that I think is reasonable. And I have patients that are on those to help support their bowels. I would say though, especially in this particular case where there are some other underlying GI concerns, I think it's appropriate to consult with a gastroenterologist and see if they have any specific recommendations, because there may be some other factors at play that are contributing. So certainly a stool softener is unlikely to cause any major complications, but I think beyond that, I would definitely consult with your gastroenterologist.
Thank you. And moving into acalabrutinib or Calquence, we have a patient here who has CLL and started treatment with Calquence 15 months ago. They're wondering how long you find it to be effective in general before another treatment is necessary.
So in a good way, we don't know, honestly, because and the reason I say that is that we've had a lot of follow-up now for all of the BTK inhibitors. And we find that even as you get out to 8, 10, 12 years out, that a majority of patients have not had a recurrence or not had progression of their disease. So I think there's every reason to be very optimistic about the length of time that this is going to benefit an individual patient. Now, having said that, there may be some specific factors, some risk factors like TP53 and other things that may apply to an individual that could play a role here. So it's hard to say for one patient, that I'm not necessarily seeing. But when I talk with patients in general, I tell them it's totally reasonable and appropriate to expect, a prolonged time before we have to think about alternative treatments. And I have patients in my own clinic that I started on therapy more than 10 years ago now that are on a BTK inhibitor doing well, and their disease continues to be under control.
Thank you. And we had two patients who are taking acalabrutinib note that they're experiencing rashes. One of them is experiencing a rash on the chest. They're wondering if that's common and if the solution is usually to switch to a different BTK inhibitor like zanubrutinib.
Yeah, so rash is definitely something that's been described. More often than not, it's something that can be managed with topicals, like a topical steroid. So again, something to talk with your team about. If it's something that is not getting better, or is really bothersome, it may be that switching to a different BTK inhibitor could help. And so it's something to think about, but often it is something that we can manage with fairly limited intervention. I will say in general, the rash and other side effects tend to get better over time. So if it's something that we can manage with topicals, I would try to give it some time to see if it may resolve, otherwise.
Thank you so much. And we did have one question here about immunomodulators. So, is there a risk of developing a secondary cancer by taking lenalidomide? And this person says they have follicular lymphoma.
So, great question. So that has been described. I would say that it's not the norm, but it is something that's been described with lenalidomide, especially in patients that are on it for an extended period of time. And so this is something as an example, we're not talking about it today, but in multiple myeloma, for example, where patients may be on it for a more extended period of time, it's something we think about. Having said that, really, any cancer treatment, and including some of the oral therapies, there's at least the risk or the concern about a secondary cancer down the road, whether it be skin cancer or issues with the bone marrow or otherwise. So it is important that anybody who's on really any cancer treatment maintain close connection with their primary care doctor, make sure that they're getting all of the appropriate screening, colonoscopies, mammograms, having dermatology, skin checks, and so forth, just as part of their routine medical care.
Thank you. And just regarding other types of targeted therapies, we had one question here, someone saying they'd love to know more information on targeted therapies for ALCL, that is ALK positive. How well do they work, and how long can someone typically stay on them?
Yeah, so great question. Um, so for ALK positive ALCL, there are some oral ALK inhibitors that have been shown to be effective. Generally speaking, these are not, at least at present, part of kind of the routine treatment approach in most cases. And fortunately, patients with ALK positive ALCL tend to have a very good prognosis and respond very well to our therapies. Now, having said that, the one sort of targeted agent that we do very frequently use in ALCL is brentuximab vedotin, and this is an antibody drug conjugate, so it's an IV treatment. So it's not necessarily oral, but it does target CD30, which is a critical target for anaplastic large cell lymphoma, and that has really changed the way we think about treating it. So in that sense, it can be very, very effective. Oral agents are something that we might think about using a little bit further down the road, and I would say the data are encouraging, but a little bit less sort of robust compared to some of these other oral agents.
Thank you. And for our final question today, I know this wasn't the main topic of today's presentation. It's a newer area of study, but we had a question about BTK degrader,
Mm.
bexobrutideg. I'm still
Mhm.
learning these because they're new. With the latest developments, do you see it possibly being used as a first line or best in class therapy? And can you speak a little bit about this treatment type?
Yes, so all very good questions. So the BTK degraders, for those that may not be as familiar, these are oral therapies that are still only available in clinical trial, but that are moving through the development pathway that actually break down BTK as opposed to just sort of inhibiting it. And so the idea is that this may be a very effective therapy, even if patients are no longer, or patients' diseases are no longer responding to traditional BTK inhibitors. They also so far have been pretty well tolerated. We've had a number of studies open at our own site and have had patients that have done very well with it. Um, I think it's too early to know exactly where it's going to end up, so I wouldn't want to speculate. But I would not be surprised to see these, number one, get approved in the somewhat near future, and number two, be evaluated either alone or in combination in frontline treatment. So again, I don't know other than to say it's a very exciting new treatment, and I fully expect that if we're here, a couple of years from now, that it'll be one of the therapies that we're talking about more extensively. The only other thing I would highlight just is to let people know that there's that BTK degraders. There's others that are also in development. So, like the BTK inhibitors, we likely will have some different options. That's over time.
Thank you so much, Dr. Cohen. And I'll add there as well that there will be a session on protein degraders, which includes BTK degraders, at the educational forum, which I discussed at the beginning of this program. And then we'll also be having a specific webinar on that later on this year. Um, More to come on that, so definitely check out our emails and keep checking our website. But I want to thank everyone for their time today. I hope today's program was able to provide you the information that you and your loved ones need. I, of course, want to encourage you to consider using the Foundation's other programs and services. In a moment, you'll be prompted to complete a brief survey, and we'd love to hear your feedback because we incorporate it into future programming. We want to make sure that our programs are as meaningful for you as possible. Lastly, in the next few days, you'll receive an email detailing the upcoming programs I mentioned, notably the Ed Forum, where you can register there. And you'll also receive a link to our publication on oral therapies, as well as our publications on specific subtypes that were talked about today, and even some other treatment options or diving into some of those specific categories of oral therapies. So thank you so much again, Dr. Cohen. I hope you have a great rest of your day.
Great, thanks. Hope everyone has a great rest of the summer.
Take care, everyone. Have a great summer.